all, I would like to thank you, all the attendees, for attending our program today. And also I want to thank our sponsor, Takeda, who has participated in this session and multiple other sessions with us in the SSBMT webinar series. So also I want to thank the SSBMT for doing all of this effort. It has been very well organized, and the sessions that has been conducted are quite informative, and that was very good from their side. So our sponsors today is Takeda, and also Novartis Oncology. So thanks for both of them. So it would give me a great pleasure to introduce two distinguished speakers. So our program today will start with Dr. David Steensma, who is going to present a 20-minute talk about how I treat low to intermediate risk MDS, a very important and interesting topic. Then we will have another distinguished talk by Dr. Roman Hajek, real-world experience in relapsed refractory multiple myeloma. After that, we will have 15 minutes for questions. So during the session, please, if you have any question, you can type it in the QA part. So it would give me a great pleasure to introduce Dr. David Steensma, who is the Edward Evans Chair of MDS Research of the Dana-Farber Cancer Institute in the Division of Hematological Malignancies, Department of Medical Oncology, and Associate Professor of Medicine at Harvard Medical School. He directs the Center for Prevention of Progression at DFCI for patients with clonal hematopoiesis and other hematological malignancies precursor conditions, and was the founding clinical director of regenerative medicine and stem cell biology course at Harvard Medical School. His main research focus is clonal hematopoiesis and development of novel therapies for myelodysplastic syndromes and marrow failure disorder. He led a number of multi-center trials and has more than 400 peer-reviewed publications. He is the editor and the chief of ASH Clinical News, and served as a member of the FDA Oncology Drug Advisory Committee, and also section editor for the GCO Hematology Examination Committee for the American Board of Internal Medicine and Education Program, chair of the American Society of Hematology. So with no further delay, Dr. Steensma, the floor is yours.
Thank you, Professor Majed. Thank you very much also to the SSBMT for inviting me. This is an honor to be part of this discussion. I'm going to give a very clinically focused presentation about myelodysplastic syndromes, and I think it's gotten more complicated in recent years. Just a reminder, we only have 4 drugs that are approved for MDS: azacitidine, decitabine, the new approval just last month of the combination with cedazuridine of the oral, Loosepaddercept, which we'll talk about more, and lenalidomide. So everything else I'm going to speak about is off-label. I don't really like this term lower risk MDS, because even the patients with IPSS lower risk disease have only a few years of life median survival. So given that progression happens at any time, is there really any lower risk patient? MD Anderson looked to see, I'm sorry, I'm just getting a lot of noise in the background, but MD Anderson looked to see with 3 different risk groups to find out who among the low risk were the particularly higher risk. And you can see they identified a group with thrombocytopenia and with higher blasts who were IPSS lower risk, but had a median survival of only about 12 months. So clearly not low risk in the broad scheme of things. In general, we are talking about IPSS very low and low risk on the revised scale. The intermediate is highly variable, however. Within the intermediate, we and others have looked to see, can we divide those patients into a higher and lower risk group? And in this analysis, patients who had more favorable disease were those who were under age 66, had few or no peripheral blood blasts, and were not transfusion dependent. And the median survival for that group was 4.5 years compared to 2.5 years for those who didn't find features. Of course, increasingly, we're incorporating molecular details. It's been almost 10 years now since Rafael Behar found these 5 genes, P53, ETV6, ASXL1, EZH2, and RUNX1, which effectively move up the patient risk group. We found that that was also true in the revised IPSS for the same 5 genes. Soon we are going to get the integrated IPSS-R with molecular, the so-called IPSS-RM. And that's going to really help us, I think, integrate the clinical pathological variables with the molecular typing. So that's enough about risk stratification. I do want to make one point, though, and that is patients who have unexplained cytopenias, who have a clonal mutation in a splicing factor or co-mutations with TET2, DNMT3A plus another mutation. They have a natural history very similar to MDS, even if they don't have defined dysplasia. So I think in the next WHO classification, we are going to see clonal cytopenias of undetermined significance, or MDS without dysplasia, included in the MDS classification. So first treatment. Let's talk about Loosepaddercept first, because that's the new approval. It is a modified activin receptor fusion protein that binds to TGF-beta family members and increases erythroid production. In the phase 2 trial, we see the median increment was 2 grams per deciliter. Many patients with ring sideroblasts went on this trial, so the phase 3 trial was restricted to those patients in order to get a label. It was patients with MDS with ring sideroblasts or SF3B1 mutation. They were low, very low, or intermediate risk, non-del5Q. They'd either been prior ESA treated or had endogenous EPA level over 200. And they were randomized 2-to-1 to receive either Loosepaddercept or placebo. And the primary endpoint was any 8-week period of transfusion independence. And you can see almost 1/2 of the patients achieved that compared to 15.8% with placebo. These are the swimmer's plots, which show that some patients had very long periods, more than 2 years without transfusions, whereas others, they counted as responders, but it was a very short interval that they had their period of transfusion independence. The adverse events, the main one is really fatigue, and that's primarily in the first couple of cycles. By cycles 5 through 8, it really gets down to similar to placebo. There are rarer things that happen. I had one patient, severe hypertension. I had one patient who just was so many myalgias, they could not get out of bed. But these are rare. And so FDA approved this for MDS with ring sideroblasts and for MDS with ring sideroblasts with thrombocytosis, the MPN overlap syndrome. It is very expensive, at least in the US. For the lowest dose, $170,000 per year So that's been a barrier for using it off-label in the non-ring sideroblast population, even though it has some effectiveness there. Now, lenalidomide, we know, works very well in del(5q) MDS, not as well in non-del(5q), but we still use it in some patients who have primarily anemia with a preserved platelet count, especially if they have a normal karyotype. The ECOG study, the MDS-05 study looked and found a 26.9% transfusion independence rate in that non-del(5) group. Now, the ECOG E29 and 50 study, that one treated patients with lenalidomide alone or lenalidomide plus epoetin. This took a long time to complete because of various logistical issues. But it also had a transfusion and a major erythroid response endpoint where the transfusion independence or 1 gram hemoglobin rise were both considered as responses for transfusion-dependent patients. So they found that the combination had a 41% response rate compared to 29.6% with the lenalidomide alone. I have to say, we're not doing a lot of this, mostly for insurance reasons. Many of these patients have previously been failed by ESAs, and the insurance will no longer let them get the ESA paid for, but these are the data, and they may be useful for certain patients. There's a lot of interest in the platelet growth factors, but responses have been modest. And in each of the randomized studies, there has been a slight increase in leukemia progression with the TPO agonist compared with the control group. This was the ASPIRE study that was published 2 years ago in Lancet Hematology, and there were a reduction in platelet transfusion needs and in clinically significant bleeding events, but it was quite modest. So now let's talk about immunosuppressive therapy. One of the hardest decisions I think we have to make is who is a good candidate with MDS for ATG or for cyclosporin or for tacrolimus. Some people think hypocellular marrow is a good indicator, but in most studies, hypocellularity is not the only predictor of response. We collected in the US with many major centers, 367 patients. A lot of them were intermediate 1, 22% low risk, and looked at what kind of immunosuppression was used. Those who only got prednisone, we removed them from the analysis. The ATG plus prednisone was the most common, with the addition of cyclosporin in some patients. And interestingly, rabbit was used more commonly with horse. A lot of these were patients who were treated 10 years ago when rabbit was more popular. So I think that might account for it. The complete response rate was low, only 11%. And there weren't very many predictors of who was going to respond. Hypocellular marrow, modest prediction. Anemia only, modest prediction for more likelihood to respond, but it wasn't very telling. Excess blast, complex karyotype, less likely to respond. And about half of the patients had some sort of response, hematologic improvement or some minor thing. So we're not using a lot of IST in lower risk MDS. What we do use sometimes, though, is hypomethylating agents. And there has been a lot of interest in alternative schedules of the hypomethylating agents. This was a randomized trial in blood 3 years ago, and a further study is going to be reported soon by the MD Anderson group. 3 days of Dacogen versus 3 days of azacitidine versus 5 days of azacitidine. And there were 91 patients enrolled, and the complete response rate was 33%. Now, I tell my patients with low risk MDS, if we're considering this, we have to keep in mind that if they progress to higher risk MDS, we no longer have the hypomethylating agent to reach for. They have used it. They have shot that arrow from the bow. And so sometimes patients will prefer to wait. The best responses in this study were seen with the 3-day decitabine regimen. And so this study is continuing, and we're hopefully going to have updated data soon. Now, the novel agents. Imetelstat, this is a study I led. It's in press at the Journal of Clinical Oncology, so should appear within a month. We treated 38 patients who had transfusion dependence. They were not eligible for ESA, or they had not responded, and they had a preserved neutrophil or platelet count. They received this drug every 4 weeks as an IV infusion, and continued that as long as it was working. We found that patients who had not previously had lenalidomide or hypomethylating agents were more likely to respond, so we enriched the cohort for them. The overall response rate was 37% in terms of those who became transfusion independent, and some patients were free of transfusions for more than 2 years. However, the adverse events were quite common, especially neutropenia and thrombocytopenia. There is right now a phase 3 randomized registration trial going on of this drug in lower risk MDS, and so we await those results. Next, ruxadostat. This is an agent that modifies the HIF signaling, the hypoxia pathway, to improve erythropoiesis even at a constant level of EPO physiologically. And this discovery of how HIF-1 alpha works won Bill Kalin and his colleagues the Nobel Prize last year. And Bill is one of the advisors. Bill is a colleague at my institute to this company. Ruxadostat has actually been approved for renal anemia in China, but it's not yet approved anywhere else. Patients who were on this pilot study had lower risk disease, no del(5q. They were requiring transfusions, but low transfusion burden, and they had an EPO level less than 400. But most of them had previously had EPO and had failed. And same number, 38% became transfusion independent in the first 28 weeks. So there is activity. The side effects were actually quite mild with this, and it's an oral agent. So this is something I think we're going to be watching to see more of data from this in MDS. It's also being tried in cancer anemia, renal anemia, in other settings. My almost last slide is to show you the randomized studies that are going on in MDS. Only 2 of them are applicable to lower risk disease. One of them is the Loosepaddercept versus epoetin as initial therapy for MDS, regardless of ring sideroblasts or not. The other is early EPO versus late EPO, waiting for transfusions versus starting right away. There's a number of other studies that are going on right now. One thing I would caution about, oral azacitidine is not the same as injectable azacitidine. The study in lower risk MDS was stopped early, even though there was activity, because of excess morbidity and mortality in the AZA arm. So it's not being developed further in MDS, but it is being developed in post-transplant maintenance, and it was just approved in post-leukemia maintenance. But the absorption is quite variable, so I would not use this as an alternative as initial therapy. So this is my last slide before my acknowledgements. Treatment algorithm, this is published, it's online, you can find it. The higher risk patients are kind of easy. They're either transplant candidates or not, and if they're not, then they get a hypomethylating agent. But the lower risk is more complicated. For those who have del(5q, lenalidomide is an obvious choice. But for those who don't have del(5q, you can choose between EPO, Loosepaddercept, if they have ring sideroblasts and have not responded to an ESA, lenalidomide even without the del(5q, or sometimes they will respond to hypomethylating agent or immunosuppressive therapy. So right on time. I think we're actually a few minutes early, so we'll have plenty of time for questions. This is my current funding and my colleagues, and I just want to thank our funding sources so that we could participate in and do this work. It's exciting that MDS finally has some new treatment options. Loosepaddercept was the first drug approved in 14 years for MDS, and now we had 2 approvals this year. They are, if you're a cricket player, it's a 1. It's not a 4 or a 6. But it's a minor improvement, but it's helpful for some patients. Thank you for your attention.
Okay, so thanks, Dr. Patterson, for the very comprehensive but also to the point talk. And thanks for even finishing before time. So before moving to Prof. Hajek, if you allow me, I just have one comment. So I think low to intermediate risk MDS is underrepresented or underdiagnosed because, patient might not be symptomatic, mild cytopenia that could be diagnosed or thought that it's something else, something nutritional, and so on. So, as a practical point, when do you think we should suspect low risk MDS and investigate for that based on your experience?
Yes, I think you're exactly right, Professor Majed. There are a lot of people out there who have MDS and don't know it. It's also a spectrum. There are millions of people who have clonal hematopoiesis. Some of them have completely normal CBC. Some just have a little bit of a broad RDW. Maybe the MCV is a little high. Other patients then have cytopenias, and they have clonal cytopenias but don't meet criteria for MDS. And then you get into lower risk MDS. So it's very much a continuum, a biological continuum. I think for most patients, if they're not having symptoms and their cytopenias are not severe, it's okay at this point to wait and to defer that detailed assessment. But eventually, often these do progress if the patient will live long enough. We don't have any data that intervening early is better than intervening later on. So I think many of these patients can be safely just observed. And in fact, if we go back one slide, I have this asymptomatic lower risk. These patients really were mostly just observing. In the future, maybe that's different. If we have something that can interrupt this process at the early stage, prevent it from going on. Just like my colleague Irene Gobriel, who's in my precursor clinic together with me. She's doing all kinds of trials, smoldering myeloma, MGUS, to try to prevent that progression. We don't know how to do that yet in myeloid disease.
So thanks so much. So now we're gonna switch gear a little bit. So from a myeloid-related disorder to lymphoid-related disorder. So I'm gonna talk about myeloma. So Professor Hajek will give a talk about real-world experience in relapsed refractory multiple myeloma, and it would give me a great pleasure to introduce Prof. Roman Hajek, who is the head of the Department of Hemato-Oncology, University Hospital, Ostrava, University of Ostrava at the Czech Republic. Dr. Hajek is the head Department of Hemato-Oncology at the university, and also he is the head of the Blood Cancer Research Group, the BCRG, International Research Team, joint project of Medical Faculty, University of Ostrava, and Hemato-Oncology Department, University of Ostrava, with number of national and international collaboration. Dr. Hajek is the chairman and founding member of Czech Myeloma Group. The RMG Registry of Monoclonal Gammopathy of CMG is one of the largest registry focused on monoclonal gammopathies in the world. Dr. Hajek has published over 500 scientific articles and book chapters, and is the editor of the one of the editors of the European Journal of Hematology. His research interests include multiple myeloma, and other monoclonal gammopathies, bone marrow transplantation, and immunotherapy. So with no further delay, Prof. Hajek, the floor is yours now.
Hello, good evening, at least here is evening. So first of all, thanks to organizer inviting me. Thank you. I have heard that SSBMT organizing such webinars quite frequently. So I think it's a really nice solution for this COVID era. So congratulations, this is really excellent. You can see name of my presentation in the first slide. So it would be focused on a real world experience in refractory and relapsed multiple myeloma. My disclosure, some disclaimer. And here is agenda. So I will start with short introduction. So why the real world data are important? I always saying that clinical trials inform, but do not reflect clinical practice. Why? Clinical trials, it's mean perfect data on an imperfect population, and opposite real world evidence means imperfect data on the perfect population. So we know that the number of myeloma patients it's general. Myeloma patients population are typically underrepresented in clinical trials. And why? Of course, this is because inclusion and exclusion criteria, mainly because patients have several comorbidities, advanced disease, they are elderly, frail, and there are other aspects and variables why the patients are not enrolled to clinical trials. And these characteristics are linked to definitely worse outcomes of the treatment. This is just example. The blue curves mean patients eligible to clinical trials, phase 3 in myeloma, red one not. And as you can see, the patients eligible always doing better, doesn't matter independently on the age. So to me, the best data, of course, are generated from several large phase 3 trials. I think some meta-analyses are even better. But then we definitely need confirmatory real-world data. And there are some initiatives which are focusing on broadening eligibility criteria to make clinical trials more representative. So we will see what's happening in the near future. So my conclusion of this introduction, there are multiple factors affecting the translation of clinical trials finding into real-world benefits. And patients and disease-related factors should be considered when choosing therapy for patients with relapsed multiple myeloma in the world setting. And it creates several questions which are listed here. I just emphasize the last one. Are the results obtained in clinical trials applicable to the real world? And I will continue with the second part. Overview of real world evidence in relapsed multiple myeloma. I will start with this presentation 2 years old from IHA by Chari. And I just highlighted range 53 to 75%. Based on the US Registry study, from 53 up to 75% of patients with relapsed myeloma were not eligible to clinical trials phase 3, based on which the critical drug for now, like carfilzomib, ixazomib, daratumumab, elotuzumab, were approved. So this is really serious, and there are significant number of patients which are not fulfill criteria for such trial. And as you can see, it's translated to not so good outcome for patients not eligible to randomized trials. The red curves mean eligible patients to these randomized trials. And you can see that except the eloquent, it's mean elotuzumab trial, For Aspire, Pollux, and Tourmaline MM1, these patients who are eligible to clinical randomized trials always doing better. And the reason why, there are several reasons as they are listed here: renal insufficiency, other malignancies, cardiovascular disease, other factors. So conclusion from this trial was really significant number of patients, more than half, do not meet the eligibility criteria for the hallmark of randomized clinical trials of approved and recommended regimen in this setting. And these results definitely again suggesting that outcome observed in clinical trials may not be generalizable to real-world patients with multiple myeloma in relapse setting. Some other data, this is data focusing on proteasome inhibitors, 3 years old, again presented by Cherry, and I just try to highlight it some things by red color. Duration of response, bortezomib-based treatment, 5 months, carfilzomib-based treatment, 6 months, not reached by ixazomib, but significant longer. And as you can see, discontinuation rates again in 9 months, 63% for bortezomib, 71% for carfilzomib, and 40% for ixazomib. The next part would be focusing on just introduction of our registry very shortly. We established this registry 13 years ago, focusing on whole spectrum of monoclonal gammopathies. Data are collected from date of diagnosis until death. And currently, there are more than 11,000 patients in this registry. And we think it's really fully functional international online database. To us, only validated registry in Europe Union, and analysis from registry are used by researchers, our group, pharma companies, and even by regulators on national and European level. Just example, this is pattern of treatment in Czech Republic, 4 years old. This is for year 2016, and it's no surprise that for first line bortezomib was the most frequent drug, 87%. For second and third line lenalidomide based regimen, and for fourth and fifth pomalidomide based regimen. At that time, anecdotally already occurred carfilzomib, bendamustine, daratumumab. What we learn, I just use lenalidomide study as an example. This is analysis of more than almost 1,200 patients, mostly treated, as you can see, in second and third line, 85% of patients. Nothing surprising in the term of overall response, but what we learn is here on this slide. At the beginning, 10 years ago, we tried to add to lenalidomide, dexamethasone, something, cyclophosphamide, other conventional cytostatic, never received better results. RD is really good regimen. And then you can see real world. RD regimen, progression-free survival, 10.2 months. I just pointed out that for control arm in all randomized trial, RD regimen achieved from 13 to 19 months. So this is the difference between real world and randomized trials. So what about real world data focusing, if you're focusing on ixazomib? There are several analyses. 3 years ago, we published with colleague from Greek and the UK, this analysis covering 138 patients. This was the first cohort. Overall response almost 70%. And as you can see on the second slide, this was 27.6 months median of progression-free survival, even better than original trial. Then the next year we presented on ASH analysis just of patients from Czech Republic, 118, and simply progression-free survival median was 23.1 months. And then we compared IXA-RD regimen versus RD regimen from our analysis. 127 patients with IXA-RD in the same period were compared with 217 patients with very similar features treated just by RD. And you can see result comparison in the term of overall response rate, nothing special, very similar outcome. But we were surprised with difference in the term of progression-free survival. Adding ixazomib to RD in real world means plus 1 year of benefit, which is really significant, and it was a surprise for us. And then finally, you're definitely familiar with INSIGHT Global Prospective Observational Study in Myeloma driven by Takeda, very ambitious project. This is just the first analysis, 2 years old, just for your impression that across the world, this is the different regimen used in relapse setting. Top 3 at the time, it was RD, carfilzomib, dexamethasone, and IXA-RD, covering 1/3 of all regimen. Other regimen, it was just mass of different schedules. We searched Czech Registry of Monoclonal Antibody as like validation registry for INSIGHT. So we did several analyses. And this is the last one presented on Paris Oncology this year in spring, covering data from INSIGHT and Czech Republic Registry, relapse patients, and you can see data. This is busy slide, so I just highlighted that median of 2 prior lines of therapy was seen for the relapsed patients in this analysis. The patients had more advanced disease if compared in original Tourmaline MM1 trial. Again, just highlighted on this slide that these patients in the real world has worse performance status than in original trials. And median time from diagnosis to start of IXA-RD was 42 months. And you can see results in INSIGHT, overall response rate 76%. In our registry, overall response 74%. And this is quite interesting slide. Median of progression-free survival in this analysis was 21.6 months. Very comparable to original trial MM1 where it was 20.6 months. But what I want to emphasize that in second line, it's mean first relapse. If the ixazomib Revlimid dexamethasone is used in second line, you can achieve really nice progression-free survival median 30.2 months. Acceptably in third line, and as you can see, for 4th line and 4th line plus, the numbers are not so good as we want to see usually. What about toxicity? There was clearly no signal about some quite unknown toxicity. Dose reduction mostly seen in lenalidomide, discontinuation similar for lenalidomide and ixazomib 44-45%. So conclusion for this, to me, the most robust analysis of IXA-RD in real world. We just demonstrate that even in more elderly, in patients with more advanced disease and comorbidities, the effectiveness of IXA-RD in routine clinical practice reaching the very similar data of original Tourmaline MM1 trial. As you can see, overall response rate very similar, 74% versus 78%, and progression-free survival 20.6 versus 20.6. And definitely the low rates of dose reduction, no signal about some unknown toxicity, and the regimen is compliance of patients of IXA-RD regimen is really high because it's fully oral regimen. This is just sum up of real-world evidence data of XRD across the world. First analysis, Terpos 27.6, second Minarzik 23.6, Lully 20.6, and finally, this year Ludwig presented data on UVA Europe Union analysis 16.2 mind. And XRD in all these analyses, reflection was this is very well related, very well tolerated regimen, no safety signal, low rate of the dose reduction, and high compliance of patients. So my conclusion, new trials are needed to enroll patients who are more representative of the targeted population for therapies. To attain benefit observed in clinical trials, need treatment regimens that are safe and practical in real-world patients to be administered for the duration given in clinical trials. And of course, we need guidance of adverse event management, quality of life monitoring, and other support. And final slide, conclusion of data of XRD. The analysis shown that effectiveness of XRD in routine clinical practice is really comparable to the efficacy of XRD reported in the Thermal9 MM1 trial. To me, this is the suggestion of patients' characteristic favoring the use of ixazomib in relapse setting. Definitely patients with slow progression, progressing relapse disease, because the ixazomib and lenalidomide regimen is not too strong. So if it's aggressive disease, this is not the best combination. We have better. But slowly progressing patients is excellent. Patients who choose to remain more independent or either wish to spend more time at home or to retain an active life, this is fully oral regimen, and this is quite important for many of our patients. Unfit younger patients or frail elderly patients, patients who live far from the hospital and have some issue with mobility. And to me, patients switching from other intensive regimen like carfilzomib RD, bortezomib RD due to toxicity, due to some, because just simply the regimen is for them too intensive, and oral regimen is appreciated with patients. And finally, in this COVID era, limited number of visits in outpatient clinic, which is allowed by fully oral regimen, 1 monthly visit is excellent. This is probably another factor which can lead to decision to use this good combination. I will stop now. Thank you for your attention, and I'm happy to answer any questions.
Okay, so thanks, Prof. Hajek, for a very comprehensive talk. So I think we have more than 15 minutes for having some questions. So if you allow me to start. So I have one question to Dr. David Steensma. So actually, I have two of them. So the first one is there any role for the targeted agents that has been approved for AML? So like the IDH1 and IDH2 inhibitors. Is there any trial using it in the higher risk MDS for that group of patients? The second question is the use of iron chelators in patients who are transfusion dependent. We know that iron is toxic to in the hematopoiesis process because it causes some DNA toxicity. So chelation might be of a use in these group of patients. So do you have any comment about that?
So first about the IDH inhibitors, yes, there are data in MDS, relatively small numbers of patients, because these mutations are much more common in AML than they are in MDS. But they do occur, especially as the patients begin to progress to higher risk disease. And they appear to have a similar response pattern in MDS as they do in AML. the label is only for AML, but they are effective. As far as iron chelation goes, this has been one of the more challenging and controversial areas in MDS for many years. Patients with MDS do get iron overload with repeated red cell transfusions, but they have competing risks such as leukemia progression, infectious deaths, and they have a limited life expectancy. So it's different from thalassemia or something where the patient will live many, many years and does not have other problems. In addition, many patients are older and they don't always tolerate very well the chelators. They may get renal insufficiency or GI upset. The randomized trial called Telesto was supposed to help answer this question, but the original accrual goal of over 600 patients had to be revised down several times, and it finally reported out with a little bit over 200 patients. There was no overall survival benefit. There was a benefit in terms of a composite of event-free survival. Some of these events were meaningful, such as liver failure or congestive heart failure, but the majority were things like need for hospitalization or mild transaminase elevation. So I think people who like to chelate found reinforcement for their practice there. People who don't like to chelate, they also were not convinced. So I think it's still an open question.
Okay, so there is a question for Prof. Hajek about real-world data for daratumumab. Do you have anything about that, Prof. Hajek?
Actually, we made some limited analysis like 2 years ago, and we published it. It was really for patients with advanced disease, and it seems that daratumumab really worked much better than any other drugs at that time. And unfortunately, I saw also the analysis from the US, Realworld data for triple exposed patients. It's mean after daratumumab or isatuximab treatment, which received other therapy. The outcome is really disappointed. If the patients are triple exposed and refractory to last treatment, the progression-free survival, independently what is given to patients, varied between like 2 months to up to 6 months. So definitely for such patients, we have still not effective treatment.
Okay, so another question by Dr. Ahmed Al-Saeed for low risk MDS into would you in high risk patient, or do you consider after a certain period of time? So Dr. Steensma.
Yes, I would usually continue as long as the patient is tolerating. We know that if you stop the hypomethylating agent, most of the time, within a few months, the disease will become more active. So we do tend to continue it. I have patients who have been on hypomethylating agent for more than 5 years. This is rare, though. Most patients within 2 years will show signs of progression or loss of response. And unfortunately, we don't have a good second-line therapy. This talk was about lower risk MDS, but in the higher risk setting, venetoclax has been added, both upfront and in the relapsed refractory setting. But that is not, again, it's not approved, and it is a little difficult to do because of the cytopenias and risk of infections with it. So we still very much need a second-line therapy. We hoped rigosertib would be a good second-line therapy, but that trial was negative, and I think that drug, at least in MDS, is dead.
Okay, so let me ask a question, Dr. Your data for
I can't hear you.
I'm not able to hear, unfortunately, either.
Either me.
Majid, maybe your voice is breaking. I could ask a question if that's okay.
Yeah, you are perfectly here.
Yes.
All right. So, David, I mean, there is this entity of MDS, MPN. I mean, if you could, give us your thought about this and how is it behaving, and would you approach it the same?
The most common MDS MPN is chronic myelomonocytic leukemia, or CMML, and it has a very variable clinical presentation. Some patients with highly proliferative disease with high white count, big spleen. Other patients really have MDS with low white count. They just have monocytosis. The genetics is a little different too. We see more commonly mutations in ASXL1, SRSF2. In addition, there's MDS MPN with ring sideroblasts and high platelet count, thrombocytosis, what was formerly called RARST. Those patients often have SF3B1 splicing mutation plus JAK2 or MPL mutation, like in a MPN patient. Those patients, interestingly, often respond well to lenalidomide, even without the 5q deletion. CMML is more tricky. For the proliferative disease, hypomethylating agents work a little bit, but not very well. We've done studies with ruxolitinib, the JAK inhibitor, and that does help reduce the white count and shrink the spleen and can improve constitutional symptoms, but it doesn't improve the marrow failure component of it. So this is a major area really of unmet need. And then there are some people who just have very unclassifiable, and they tend to have a very poor prognosis, actually. Many of them progress to leukemia within 1 to 2 years.
So when they progress, and when they have anemia as the predominant feature, that's transfusion dependent, not responding to erythropoietin. So what would be your next for this MDS, MPN, sideroblastic?
Yeah. So Loosepaddercept does work in that setting, and it is now approved for that. We actually have had some pretty good experience with lenalidomide in that setting. The first paper was just 3 cases from a Dutch group in 2010, Gert Hulse, and it was published in Blood. But since then, more experience has accumulated, and we have a paper in Press now with almost 100 patients showing a response rate of about 40% with lenalidomide with MPN RST. So those are a couple of the options. The biggest problem is if you use something like hydroxyurea to lower the platelet count, the anemia gets worse.
Yes.
And that's the difficult part.
Correct. Majid, you're back with us. You're mute, I think. Majid?
I just had a problem with my internet connection. So, okay, so I have a question here about the biochemical relapse in multiple myeloma patients, which is a topic that has not been studied so much in the RCTs. So the question is, how do you find this group were properly represented in real life? And what's your recommendations, Dr. Hajek, about for treating these group of patients?
Thanks for this question. There are several angles. Of course, there are specific trials now opening, which are clearly focusing on patients with just biochemical relapse. And it would be really nice to see reproducible data from several trials. So far, we know first data and outcomes. It seems that simply treat sooner means better results. The second thing is what to do in real life, and especially I remind you with our recommendation for treatment of myeloma in COVID era. We just published it recently in leukemia as a Europe Myeloma Network Consortium. And the recommendation in COVID era is not to treat biochemical relapse because it's not any urgency, and it is in some extent tough epidemiologic situation. It's much better for our patient wait, be monitored, and start treatment really if it's needed, which is not biochemical relapse, in fact.
I have no more questions from the audience that I could see. But I have one last question for you, Dr. Hajek, about the safety that you have noticed in real world for using the ixazomib in frail patients with myeloma. One of the challenges that we have here in Saudi Arabia, that diabetes is very common. And with drugs like bortezomib, we see a good proportion of patients that are having grade 1, grade 2 peripheral neuropathy. Rarely we see more than that. Based on your experience, what was your finding in the real world data for peripheral neuropathy?
You mean for ixazomib or general? For
no, ixazomib. For ixazomib.
You know, from randomized trial, the frequency of neurotoxicity is up to 20% if the ixazomib is used, but this is mainly like 90% just grade 1 or 2. So it's much lower than if compared with bortezomib. And for real world data, what we have, at least in our registry, the frequency of neuropathy is even less. So it's no more than 10%. And as the many patients were treated by bortezomib and then received ixazomib lenalidomide, we can see in some subgroup of patients even improving of neuropathy. So from grade 2 painful to grade 1, which is really nice. And this is just like factor which have to be considered, because we have to evaluate neuropathy at the beginning of any treatment. And this is still something which was done by treatment before and which will be improved during the time, independently of given treatment, of course, if the drug has no significant neurotoxicity. So ixazomib, from my point of view, creates some really limited neurotoxicity in the real world.
Okay, so at the end, I would like to conclude the session. And first, I want to thank again our speakers, Dr. Steensma and Dr. Hajek, for accepting the invitation and for the very informative, comprehensive talks. And again, to thank our sponsors, Novartis and Takeda, and want to thank the SSBMT and for all of you, the attendees. And we want to remind you for the upcoming session, which will be on next Saturday, the 17th, on the same time, by Dr. Ayman Hijazi, the CML Epidemiology in Saudi Arabia, and Dr. Andrea Hodges, How I Treat Newly Diagnosed Chronic Myeloid Leukemia. So see you soon, inshallah, next week, and thanks very much.
Great. Thank you.
Good evening.
Thanks. Have a nice day.
Bye-bye.